Now, in continuation of the previous lecture series, now moving towards second series, that is state of the art. And moderators for the session is the Dr. Anshu Srivastava, and chairpersons are Dr. Rachit Agarwal, Dr. Balwant Singhil, Dr. Jay Toshniwal, Dr. Rajendra Pujari. I would like to call them, please come on the stage. And this is a reminder to all that after this session, we will be having a lunch break.
Good afternoon, everybody. We have been hearing a lot about the mimickers of GR, when to use PPIs, when not to use. But I think before that, we need to know how do we actually diagnose GERD and when do we say that it is not GERD. And for that, I would be very happy to invite none other than Professor Ajay Kaul, whom we all know has a lot of work in this area, and he'll be talking on the diagnosis of GERD and NERD in 2024, optimizing the use of pH impedance tests in practice. Professor Kaul, please.
Thank you for the organizers for inviting me. It was really a pleasure to be back home in India and amongst my fellow Indians. And thank you for the introduction as well. So the topic that I was given was diagnosis of GERD and NERD in 2024, optimizing use of pH impedance studies in practice. These are my disclosures. The learning objectives are to discuss the indications and various testing modalities for diagnosing GERD based on the Lyon Consensus version 2. That's the latest one, and I'm going to just focus on that. I was also asked to focus specifically on the role and specific metrics of pH impedance testing in diagnosing GERD. So I'll spend a lot of my time discussing that. The good thing is that you've already heard a lot of things, and what I'll do is try to put all that you've learned this morning into the context of GERD. So GERD now, as you know, is a heterogeneous disease process that is impacted by an array of symptoms, patient factors and comorbidities, neuromuscular and psychological factors, anatomical and functional issues. And one of the speakers today, Dr. Ravi Mata, has been excellent, and he's done a lot of research on that. And I just have to make a clarification. Ravi, I didn't say that you were controversial. I said you were provocative. There's a difference between controversial and provocative. So GERD is also a very commonly diagnosed or misdiagnosed condition. It's a chronic condition and expensive because a lot of health dollars are spent on that, or health rupees. It needs more objective measures to better diagnose GERD because, like I said, it's often misdiagnosed and treated. It's good to know exactly what you're treating, and so therefore having a definitive diagnosis of GERD impacts management and patient outcomes as well. There are a lot of new potential interventions for GERD, as you just heard an excellent talk. And you need to know, you have to say, for example, if you're going to recommend an anti-reflux surgery or intervention, you need to be sure that it truly is reflux and not some other condition as mimicker, as the introduction said. And then you also heard a really good introduction to the personalized treatment approach for GERD. And I'm not going to discuss that for this talk. So there's been an evolution in the definition of GERD. Back in the day, in 2006, we used the Montreal definition because up until then, there was no consensus on the definition of GERD. The Montreal definition described GERD as a condition which develops when reflux of gastric contents cause troublesome symptoms and or complications. As you can see, there were a lot of problems with this definition. There's no pH impedance at that time. We didn't learn as much as we know now, and it wasn't incorporated into the definition. So it was based only on symptoms and endoscopy findings and did not include any pH metry or other metrics. So the Lyon one, the latest one, it provides conclusive and versus adjunctive factors that support or refute the diagnosis of GERD categorically. So this is just a slide to show you how the definition of GERD has evolved over the years based on technological advancements in diagnostic tools such as impedance. And also, unfortunately, in pediatrics, I'm a pediatric gastroenterologist, that's my disclaimer, we still use the Montreal definition from 2006. In the adult world, they've moved on to the Lyon 2 consensus that was published in 2023. So it really reflects the culmination of the knowledge acquired that we've acquired over the years from all the new technologies. So going on to my talk, I'm going to talk about the 5 elements that have been described by the Lyon Consensus for GERD diagnosis: clinical history and GERD questionnaires, PPI trial, EGD and esophageal biopsies, and like I said, I was asked to focus more on ambulatory reflux monitoring, and then of course a little bit about high-resolution esophageal manometry, a lot of which you've already heard. So what about history and questionnaires? The typical history of GERD, as you know, there's 3 symptoms: heartburn, regurgitation, and non-cardiac chest pain. You always have to make sure that what you're thinking is reflux is not really cardiac, because it only has, typical symptoms only have 70% sensitivity when you compare to pH metry or endoscopy. So if there's a group of patients that have endoscopy and pH metry data, and they have typical symptoms, only 70 of them, it has only 70% sensitivity. So that's really not very good. So just in fact, going on symptom alone is not the best thing to do. Medication trial PPI for 8 weeks, given PPI should be given the right way, on an empty stomach before meals, and should be given for 8 weeks. And this is acceptable for typical symptoms. So if you have typical symptoms, and as I said, the typical symptoms are heartburn, regurgitation, and non-cardiac chest pain. If you have any of those, yes, you're correct in treating it with 8 weeks of PPI. What about questionnaires? Symptom-based questionnaires are essentially been scratched out, and nobody ever uses those questionnaires anymore. Back in the day in US, there was a big trend to giving these questionnaires to patients to see if it worked, but it really didn't. What about PPI trial? So the medication, like I said, PPI trials for 8 weeks is acceptable for typical symptoms of heartburn, non-cardiac chest pain, and regurgitation. Unfortunately, the sensitivity and specificity are not that great, especially the specificity is only 44% compared to EGD and metry, pH metry. Interestingly, 33% with documented GERD, meaning they have definitive diagnosis of GERD on endoscopy, do not respond to PPI therapy. And on the reverse is true too. More than 33% with normal endoscopy and pH metry who you think have GERD actually respond to a PPI trial, which reflects a placebo effect. So this is the approach to evaluation that the Lyon 2 consensus gave. So if you have typical symptoms like we talked about, an empiric trial for 8 weeks for anti-secretory therapy. And if you have atypical symptoms like belching, which you heard of, a very eloquent lecture on belching, it's less commonly associated with GERD, but it's definitely seen, and therefore you need to do the endoscopy, pH impedance monitoring, and HRM. For the other atypical symptoms of chronic cough and asthma, you really need to do pulmonary evaluation first before you start doing GI endoscopies and impedance. So first, and then make sure the pulmonologist has seen them. And then atypical symptoms of hoarseness, globus, nausea, abdominal pain, dyspepsia. These are really very unlikely to be associated with GERD. Also, the small percentage still may be associated. And for those, you do the investigations only to prove the association, that it is reflux or not. So moving on to endoscopy and biopsies. Endoscopy should be performed in those with atypical symptoms, red flags, or PPI non-responders. Again, PPI responders is a whole lecture you could hear. Here on PPI non-responders. There's several reasons for this. A lot of that you heard earlier in the talk. It could be because of genetic reason, pharmacogenetics, CYP19 enzyme deficiencies, or over metabolizers, rapid metabolizers, etc. You need to make sure that it's not one of those, and you've given an adequate trial before you do the endoscopy. But 70% of adult GERD and 80% of children with GERD, definitive GERD, have normal endoscopy. So EGD is specific, but it's not sensitive in GERD diagnosis. So the Los Angeles classification, as you're all well aware of, grade A is not considered diagnostic for GERD because it's found in about 10% of healthy adults. But grade A, B, C, and D, which is erosive esophagitis, are considered diagnostic for GERD. So if you see that in an endoscopy, there's no need to do a pH impedance or further investigation. You diagnose that patient with GERD and move on with therapy. Again, if you see complications of GERD on endoscopy like peptic stricture or a biopsy-proven Barrett's esophagus, these are also considered diagnostic for GERD, and you do not need to do any further therapy to diagnose it, but go ahead and treat. What about biopsies? Now it's changed to that it's you should always, if you have a negative endoscopy in a patient who has GERD symptoms, always take biopsies. And you heard a good reason for it in the previous talks about EOE, how it can be have a completely normal appearing esophagus but still have EOE. So always take biopsies. Microscopic esophagi, specifically dilated intracellular spaces, are present in all GERD phenotypes, and we'll talk about GERD phenotypes in a little bit. And it's helpful in diagnosing NERD, non-erosive reflux disease. The caveat is that 65% of patients with reflux hypersensitivity and 13 with functional heartburn also have microscopic esophagitis. And it is seen in healthy adults. 15% of healthy adults will have some dilated intracellular spaces and have poor correlation with symptoms. Moving on to the main thrust of this talk, ambulatory pH monitoring. You could do pH metry, which includes wireless Bravo system, or pH and impedance. The pH metry are two kinds, as I said. One is wireless, one is with the catheter based. The left is the traditional one that we have had for many decades. It has the catheter going into the esophagus with the pH sensor in there and the recorder. And on the right, you see the Bravo system, which is endoscopically placed. It's wireless, and it communicates wirelessly with a recorder that's worn with the patient. The typical tracing that you see is shown in the bottom. You only have a pH tracing, and you can associate that with symptoms such as heartburn and meals, as shown in this slide. Now, moving on to pH impedance. pH impedance is a relatively newer technology, and it is a kind of involved process. It's not that easy to set up, and a lot of people make mistakes with this, and that's why I'm kind of showing this slide. You have to calibrate your catheter extremely carefully. There's those calibration liquids with a pH of 4, 7, and sterile water. There's a whole system of virtual instructor online that will guide you through the calibration process. And you have to make sure that you ask the patient to avoid acidic foods, chewing gum, carbonated drinks, and foods at extreme temperature while doing the study, because it can affect the study. So when you've placed the catheter, this is a pH impedance catheter in a child. In pediatrics, we recommend 2 vertebral bodies above the lower esophageal sphincter, as shown in the left picture. In adults, it's 5 centimeters above the lower esophageal. Then that's the consensus. On the right, you see the channels. Between the first and second sensors is the first channel. Between the second and third sensor is the second channel, and so forth. The lowest channel is number 6, close to the pH sensor. And what you see on the right is a tracing that you record from the pH impedance. You can see the impedance baseline, and then it drops. The drop in impedance is from below upwards, and that reflects a reflux, as opposed to from above down, which reflects a swallow. Once you finish the study, it should be an ideal duration of 24 hours, but a minimum of 18 hours. There should be an overnight component to the study, recorded with meals. And remember, the GR events during meals are excluded from the automated analysis, but this you can change on your system. Depending on which vendor you have, which system you have, you can change that. Some people like to include meal times in the analysis. Manual visual inspection to add, delete GR events throughout the study, and you look for specific patterns. Why? Because the software has a lot of limitations, and we'll talk about that. The 2-minute time window before a reflux event for reflux association. So when a patient hits the button for event for cough or regurgitation, the software will go back 2 minutes to see if there was a reflux event that happened, to call it a true association of the reflux event with the symptom. Now, there's a caveat to that. If the patient doesn't hit the button within 2 minutes, or does not hit the button at all and he's still having symptoms, you're going to miss that. And it can take up to 2 hours or more to completely analyze a study, especially if there are a lot of reflux symptoms. So it's pretty involved. So essentially, this is what I was talking about, how to differentiate a liquid swallow from a reflux. You see the baseline impedance. Sorry. You see the baseline impedance in the lower three channels, channels Z4, 5, and 6. And you see how from the baseline, the impedance has dropped to more than 50% before the software calls it a reflux event. So that's another problem. So the software is adjusted to the point where if the impedance drops below 50%, only then will the software call it an impedance. So what if it drops only 49%? The software will not call it a reflux event. So therefore, you really have to manually go through each and every episode and see if it is truly a reflux or if there were some missed reflux events. The right is a true reflux event where the impedance drops to below 50% from below upwards, and it's a full column reflux going from bottom to the proximal esophagus. So some software definitions. Let's go at the bottom, the distal two channels. Look at the lowermost channels. What is a reflux event? I told you when the impedance drops below 50%, the baseline, in the lowest two channels, only then will it say the recorder will record a reflux event. What if it only drops below 50% in the lower channel and not the second to last? It will not record it as a reflux event. So there's a lot of caveats and limitations you have to be aware of when you're reviewing a study. Similarly, in the proximal channel, the proximal events, the impedance has to drop below 50% in the top two channels. So what if it doesn't reach the top channel? Are you going to call it a proximal event or not? So again, limitations that you need to be aware of. A little bit about bolus clearance. You can see how there's a reflux event here. And is it acidic or non-acidic? It is acidic because in the lower panel, you can see the pH channel. You can see the pH is dropped below 4. So this is an acid reflux event. And then there's a swallow. How do you know there's a swallow? The impedance went up and then dropped again from top down. So this is a reflux event with a reflexive swallow, which supposedly should clear the esophagus of all the contents, acidic contents. But here it has not. The patient had a reflux event, the bolus is cleared, but the acid is still present there. And that period from the time of bolus clearance to chemical clearance to the end of pH 4 going up to baseline is called chemical clearance. Symptom correlation, I kind of alluded to this before. The patient hit the button at this point here. I'm having trouble with that marker. But anyway, you see the red dot there, that's where the patient hit that he was having pain. And the software goes 2 minutes backwards to see if there was a reflux event, and there was. You see the impedance is dropped from below up. So is this a pH that's below 4? No, the pH is above 4, it's 5.6. So this is a non-acid reflux event, which would not have been picked up by a pH metry alone. So you need impedance to pick up these symptom correlations. So like I said, there's a lot of software limitations that you need to be aware of, like many of them we discussed already. And then more importantly, there are certain features that are only identified by manual or visual review of tracings, and we'll quickly go through that. Aerophagy, for example, belching and burping, rumination, low baseline impedance, retrograde UES dysfunction, and 2 novel impedance parameters that you heard of earlier, post-reflux swallow-induced peristaltic wave, PSPW index, and mean nocturnal baseline impedance. And we'll talk a little bit about these. So very important to do pattern recognition of impedance tracings. The software-generated report does not recognize any of these. So if you have an impedance system at work or you use it, please review the tracings. Take some time to review the tracings because there's a lot of information in this that you could misread and the software will miscalculate. So please be aware of that. So this is a classic example of a patient with aerophagy and burping. You can use the animation tab, which is shown in the red arrow up there. When you hit that, the right panel shows up right here. And you can see that the patient and when it animates, and you can see the air, which is shown in blue, you keep swallowing, the air keeps coming. And there's a reflux event that is associated with it. And it's an acid reflux event because the pH here is 3.5. Right? So this will move, the line will move, and you can actually see in 3D, you can see the movement of the air in the esophagus. And this is very characteristic for aerophagia and burping. And you can see the burping as well coming from below up. So the burping is going from the bottom of the esophagus to the proximal esophagus and out. Rumination, this is a typical picture of rumination. So when you look at the bottom panel, you see a lot of reflux episodes, and they're typically after a meal. As you can see, this is the meal line, and then a lot of reflux episodes, then another meal here, and then a lot of reflux. And when the patient is sleeping, there were no events, right? And then really all of these events were full columns. So meaning there was not just a low grade reflux for 2 to 3 channels in the lower esophagus, but all the way up to the proximal esophagus. So 60-70% of the episodes were up to the proximal esophagus. Normally, an adult should not be having many proximal reflux. Most of the reflux events are to the lower channels. Okay, so that's another sign of rumination when you review this. Again, the software will not give you this diagnosis. You have to actually sit down and go through the entire tracing. Low baseline impedance, this is another example. If the impedance is low in the lower channels, as you see in patients that have a tight fundoplication, you're doing an impedance for that reason. Or there's a child that has TEF, tracheoesophageal fistula surgery, and is having dysphagia, and you think it's reflux, and you do an impedance. The impedance is placed, and you see in the lower 3 channels, the impedance is really, really low. This software will not pick up any reflux events because the impedance is already so low. You need a 50% drop. If it's already so low, it's not going to fall any lower. So you will probably get a result that there were 3 episodes of reflux, but that's not correct because the lower channels were full of fluid, persistent bolus presence there, and that's why the reflux events were not picked up. And this was actually a case of dysmotility, not reflux. This is a newer condition we just reported in pediatrics as well, retrograde cracopharyngeal dysfunction. And I'll focus your attention. I can spend an hour on this, but let's just focus on the impedance panel here. You see what the patient is doing is, this is a reverse of burping. The complaint is the patients come in with the complaint that they cannot burp and they make weird croaking noises like a frog croaking. And when you do an impedance study, you see that the patient is unable to really burp, or the upper UES sphincter does not relax, as you see in the manometry here. And you see the impedance channels all going up, meaning there's air in the esophagus, but the UES is not relaxing to let the air out. But swallowing is normal. When they swallow, the UES will relax normally. It's just that it does not let it relax to let the air out. And there's a lot of air trapping. So if you see the impedance, there's a lot of air blue all over through most of the study. And the carbonation protocol is something we follow now. We give a carbonated drink, and this becomes much more pronounced. And that we just published that paper, and you could potentially read that as well. What about symptom reflux association? We talked about how the symptoms preceded by a reflux event in previous 2 minutes is important. What if the patient doesn't hit the button, or if he hits it more than 2 minutes later, it's not going to record. Your software, essentially, I'm saying the software is not useless, but you really need to put in manual effort in there. The 2 symptom reflux association indexes that we study is symptom index and symptom association probability index, at which both of them predict success of therapy in adults. But neither of them is ideal. They do not tell us about a cause and effect relationship, just an association. Symptom association is very critical for differentiating reflux hypersensitivity from functional heartburn. And this is one of the reasons why in pediatrics it's really hard to diagnose these 2 conditions, because this is the most, symptom association is the most difficult to challenging to calculate in children, because they never hit the button, the mother forgets to hit the button, or there's several reasons for that. So among the symptom association analysis, we no longer follow the symptom sensitivity index, the SSI. Nobody follows it now. You usually just use the symptom association probability index, which is SAP, or the symptom index, which is on the left side. And the threshold is 50% or more in symptom index and 95% or more in symptom association probability index. Now, the reliability, as I said earlier, this is a patient, as you can see, had a reflux event here. It was acidic because the pH dropped to less than 4, and the impedance dropped from below upwards, and it was a full column reflex. And he complained. He hit the buttons for cough, pain, and regurgitation during this time. The software went 2 minutes back and said, yes, there was an acid reflux event, so this was acid reflux associated with these symptoms. However, a few minutes later, he had another acid reflux event, a prolonged one, much more severe than the first one, and the chemical clearance was much longer, but he had no symptoms. Why? Because he was sleeping and he forgot to press the button. So it's very, you will only know this when you're actually seeing the software is not going to do this. So artificial intelligence, beware. Now coming to GERD phenotypes, and this GERD phenotypes is based on your endoscopic findings and pH impedance. The first is the classic GERD, which is EGD positive or pH metry positive. Then there's non-erosive reflux disease, which is EGD negative but pH metry positive. Reflux hypersensitivity and functional heartburn, we'll talk a little bit more about these. They are both EGD negative. So this is according to the Lyon 4 consensus, the latest one, based on EGD impedance. GERD, as I said, if you have LA grade B, C, or D, or you have a peptic stricture, or you have Barrett's esophagus, you could make a definitive diagnosis of peptic ulcer disease or GERD and move on. You don't need to do anything. Or if you do a pH impedance and the acid exposure time is more than 6%, the number of reflux events is more than 80, and SAP is positive, so this symptom association probability index is positive, then you can make a definitive diagnosis of GERD and move on, treat the patient. NERD, you may have a normal endoscopy or you may have LA grade A. But when you do the impedance, it's abnormal. Acid exposure time more than 6%, number of reflux events more than 80, and SAP is positive. What is reflux hypersensitivity? The endoscopy is normal. The pH impedance is also normal, but the SAP is positive, and the mean nocturnal baseline impedance is abnormal. I'll talk a little bit more about that later. And how is it different from functional heartburn? Everything is normal in a functional heartburn. The patient is complaining of chest pain and heartburn, but the endoscopy is normal, the pH impedance, all parameters and metrics are normal, including SAP and mean nocturnal baseline impedance. So coming to, as I promised, we talk about two new metrics, the mean nocturnal baseline impedance and post-reflux swallow-induced peristaltic wave, PSPW. You heard a little bit about that earlier. I'm not going to belabor that with you, but that's not been included by the Lyon consensus at this time. And there's a few things that have come up since the 2023 publication, especially the one that Dr. Shobna talked about, the Milan maneuver, the leg raising and looking at your metrics. That's not been included in the Lyon consensus right now, but hopefully it will. And neither is the endoflip. And I think in the future, endoflip measures and metrics will also be included in GERD diagnosis as well. So what is mean nocturnal baseline impedance? As the name suggests, essentially is the average of baseline impedance when you're sleeping. And it's an expression of integrity of the esophageal mucosa, which is impaired in any form of gastroesophageal reflux disease. And the cutoff that they gave was 2292 ohms. So if your mean nocturnal baseline impedance is less than 2292, it's an even better predictor of a good response to therapy than acid exposure time in adults. So this is how you calculate it. Again, the software does not calculate this. You have to calculate it yourself. You see this is while the patient is sleeping. The patient is sleeping. Your baseline impedance is static. It's not changing up and down. You choose the 5 centimeters over the LES and see what the impedance is there, and you take a few readings. And if it's less than 22,000, it's abnormal. And you can it's supportive of the diagnosis of GERD. This is the post-reflux swallow-induced peristaltic wave that one of the previous speakers talked about. You have a reflux event. You have an acid reflux event. The pH is dropped to below 4. The impedance dropped from below up. And then there's a clearance swallow. The patient swallows and clears the acid. As you can see, the acid pH has gone back to baseline here after the swallow. So this is a post-reflux swallow-induced peristaltic wave. If the PW, you don't see very many. They don't have any standards for this right now, and that's why it has not been included in the Lyon's consensus right now. It is an independent factor associated with PPI success, 92%. I'm not sure why. I think it's because they don't have, they need more studies to include that into the Lyon consensus. Maybe the next one. So, who gets pH metry impedance, and whether do they get it on medications or not? This is essentially the sum or gist of the whole thing. If you have, like I said, grade A, B, C, B, C, and D esophagitis and biopsy-proven Barrett's mucosa and peptic esophageal stricture, you definitively make the diagnosis, or the abnormal metrics I talked about. If you are not sure about the diagnosis, then you're unproven. You do the pH impedance on off medications. Take the medication off for 7 days is what they recommend. So week off of PPI, and then do either wireless pH monitoring or catheter-based monitoring pH impedance. If you know for sure the patient has GERD, meaning they had in the past grade B, C, or D, LA grade B, C, or D, or peptic esophagitis, or Barrett's esophagus, and the patient is not improving, then you do the study on PPI and the same high dose that you've been giving, and then you look. And the Lyon consensus actually gives you metrics for off PPI therapy and on PPI therapy for refractory GERD. Moving on to the last high resolution esophageal manometry, Dr. Ravi Mittal spoke to you beautifully on this. I'm not going to belabor this. Here you see a typical transient LES relaxation and a reflux event followed by a PSPW or swallow. New HERM recommendations from the Lyon consensus, they added this to their recommendations. It's mandatory to do HREM now prior to considering any anti-reflux surgery. Please do not skip this part. Several motor abnormalities have been described on HERM in GERD, both hypo and hypermotility. You evaluate the EGG anatomy and esophageal body peristalsis and contraction reserve, and you heard a lot about that earlier. You calculate the separation of the LES and the pleural diaphragm. You measure the contractile integral of the EGJ junction. And as you can see in this picture, there's a hiatal hernia there, the separation of the LES and pleural diaphragm. And on the right, you see the EGJ contractile integral. And as the previous speaker mentioned, both hypomotility and rare cases of hypermotility are associated with GERD as well. And worse the symptoms, worse the motility. And then, of course, the contraction reserve, peristaltic augmentation on provocative maneuvers. You heard a lot about that. I'm going to skip. But remember that 70% of patients with erosive reflux disease and 20% of healthy adults do not have effective peristaltic augmentation. So they will not augment, and you may call it out. So be careful about that. This is the rabbit drink challenge, contraction reserve testing, and I will leave you with this slide for conclusion. Thank you very much for your attention.
Please join us on the dais. Please join us. Now I would like to invite for the second talk Professor Yong Ye Lee. He is going to talk on a very important, relevant topic of electroneuromodulation in disorders of gut-brain interaction. We have all experienced patients where we are really stuck and we don't know what to do next beyond medical therapy. So let's hear from him the current state of affairs.
Right. Good afternoon, and thanks very much for the very kind introduction. Now, my objective really is to, first of all, in order to understand electroneuromodulation, we need to understand the gut-brain regulation of symptoms and also the rationale for doing electromodulation. And then I'll talk about methods, whether being direct or indirect stimulation, and lastly, on the application on which DGBI or disorder that we will use electroneuromodulation. By the way, I coined the term electroceutical here. This is basically application of electrical stimulation in medical practice, or you may say similar to electrical vehicles. So this is a slide adapted from Douglas Drossman, where he elegantly put up the different influences on symptoms, severity of symptoms, from one spectrum being mild to the more severe and with more symptoms, with more of a disinhibition, with mild being affected mostly on the efferent excitations. And all of this can be affected by diet, infection, injury, and on the other spectrum, life stresses, psychological disorders, poor coping, abuse. And we do have options in terms of treatment when it comes to targeting different severity of the disorders. Again, a very important part of regulation is the gut-brain axis. The pain experience itself may actually a result of peripheral injury causing central sensitization, or it could also be part of this pain pathway, the small fiber and the large fiber pathway being amplified in patients with disorders of gut-brain disease. And this will again be affected by numerous factors, including chemicals or structurals, mood disorders, genetics, cognitions, as well as autonomic dysfunction, where if you have a sympathetic overactivity, it may result in hypersensitivity. But if you have a parasympathetic hypoactivity, then this would result in a hypomotility. Another frequently heard term would be the gate control theory, and this is where acupuncture treatment comes in, and it helps in modulation of the nociceptive uh, pathways. And of course, we also probably would heard about how this pain experience can be modified by this vagus nerve as well as the descending inhibition path. The other important terms that we like to understand would be neuroplasticity. Basically, at the basal state, every neurons would have a basal neuroplasticity, and because of inflammation, then it may result in a suppressed form of neurogenesis, and by through treatment, for example, using antidepressants, neuromodulation, or even behavioral therapy, then it helps in restoring the neurogenesis. So now let's talk about the various methods of electrical neuromodulation. First, we have what we term the direct nerve stimulation, and this is where we need a surgical placement of stimulating electrodes, as well as you need a generator. This allows an automatic delivery of very long period of time, and therefore this form of electrical stimulation would be more suitable for chronic disorders like epilepsy or even obesity. The direct GI electrical stimulations are basically implanting electrode directly on the serous surfaces of the GI tract, including esophagus, stomach, small bowel, or even large bowel. And because it stimulates the serous surfaces, it may have excitatory effect or even inhibitory effects. And because of this reason, we need to configure the parameters more carefully in order to effect the correct clinical effects. The other would be a transcutaneous stimulation. This is more non-invasive, involving the superficial nerve and without any direct contact. And because of this reason, it can be self-administered and very good for mild to moderate GI symptoms. So let's talk about the direct nerve stimulation here. And one of the more commonly form would be the vagal nerve stimulation. And all of us would know that as a vagal nerve itself is a parasympathetic nerve. And when we do stimulate this particular nerve, we will be affect the upper GI tract until the proximal part of the colon. We tend to implant it either through cervical root, as I shown in this diagram here, or it can also be placed subdiaphragmatic. And most of the time, we will stimulate on the left side. Now, cervical placement of the stimulation will be much more simple. The only problem is some of these patients, they may have adverse effects, including respiratory dyspnea or even cardiovascular rhythms effects. And there have been some studies showing that the beneficial of this method in Crohn's disease. SNS or sacral nerve stimulation, again, sacral nerve itself is parasympathetic and it only involves the lower part of the anal rectum until the distal part of the colon. In fact, sacral nerve stimulation is probably one of the earliest form of electroceutical. It has been in existence since 1986. Sacral nerve stimulation has a focus on the S3 nerve roots, and it doesn't have any adverse respiratory or cardiovascular effect just because it only involves the lower GI tract. And probably the most common form of direct nerve stimulation would be through the spinal cord, where our neurosurgeons and orthopedic surgeons would have used. And they tend to involve multiple electrodes for a very specific nerve that they want to stimulate. And very good for those who have a chronic pain in the trunks. However, certainly there are some studies suggesting that even spinal cord stimulation may be useful for gastric disorders and some chronic pancreatitis pain. Now let's talk about a direct GI serosa electrical stimulation. This can be in the form of a long pulse, as you can see here. This is how a pulse would have looked like through a long pulse stimulation. And the long pulse is designed to pace the gut in order to change the intrinsic smooth muscle activity. And because of that reason, the pulse wave tend to be wider in duration, between 10 to 600 milliseconds. And if your pulse frequency is higher than the intrinsic pacemaker in the gut, then it may improve the motility. But if you were to pulse it even higher or longer, then it may inhibit motility, which is something useful in the treatment of obesity. The other form would be a short pulse, and this usually in the typical range of few hundred milliseconds. It does not affect the smooth muscle activity, but it does have an effect on the autonomic systems, although being less effective than a direct stimulation. An example would be the Enthera system, and this particular system is FDA approved in the United States for treatment of nausea and vomiting because of the gastroparesis. And lastly, there's another form would be what we call as a pulse train or burst stimulation. This is more like intermittent, as you can look at the diagram here, rather than continuous like the long pulse or the short pulse. And because of its intermittent nature, it has an on time and an off time, something like a Parkinson's disease. Last would be the transcutaneous electrical stimulation. One of probably the common or most exciting studies that now ongoing in TGBI would be through transauricular vagus nerve stimulation. This is how we stimulate through our auricular region. This particular area that I've shown here in blue or even in red is purely innervated by the vagus nerves. And through this afferent excitation all the way through the nucleus tractus solitarius in the brain, the only challenges is that how do we get a proper contact with that area in the ears, and how to develop a true wearable device to make it useful clinically. The other method would be what we call the transcutaneous form of vagus nerve stimulation, and this is using an external device. Again, an example would be a gamma core, as I show in this figure here. And this particular device is FDA approved in the United States for treatment of migraine and also cluster headache. And because of its easiness to use, it can be delivered even a few times a day, each time only a few minutes. And more recently, this particular method has been shown to be useful for gastroparesis. Lastly would be trans-electrical acupuncture. This is where you stimulate certain acupuncture points, for example, the ST36. And this particular point is situated below the kneecap. It actually stimulates the peroneal or very near to the peroneal, sciatic, and the tibial nerve. And the other commonly used acupuncture point will be the PC6, and this is very near to the medial nerve. So let's show a case study here where a 24-year-old female G2 para 1 post-delivery with a third-degree tear with an urge incontinence. Both the external and the intrinsic anal sphincter have defect based on the UES, and the manometry findings suggest this patient has anal hypotension, hypocontractility, and a rectal hyposensitivity. We did the biofeedback, but only partial response despite giving 6 sessions. So what else can we actually offer for these patients? And this particular review that we did quite a while ago will be probably useful in looking at what are the alternative approaches for constipation and fecal incontinence. Now, when you look at evidence for sacral nerve stimulation, it's probably the most beneficial for fecal incontinence and not constipations. And the efficacy, as you can look into this particular table, is very useful in reducing the frequency of the incontinence, improving symptoms, as well as a quality of life. The only problem with SNS is obviously limitations, and you need your help from your colleague, the surgical colleague, to help do the implant. And because there is an implant, it can cause pain, infection, there may be a potential for cable breaks, and sometimes you even need a surgical revision in a third of our patients. Also, you probably need to understand that the mechanism for how SNS being effective is not because it improves motor, but it improves the sensory feedback and also improving cortical awareness. Now let's look at a few examples of application. First of all is the functional dyspepsia. You can use the acupuncture stimulation for FD, and there have been several small studies showing efficacy between 35 to 55%. There's also a study using transauricular vagal nerve stimulation in functional dyspepsia, and again, it can help to improve symptoms. It also improve psychological dysfunction, and it done this by enhancing the vagal activities. There's also inferential stimulation, and this basically, as you can look in this diagram, you have several electrodes placed at the back of the patients, and inferential means you use alternating current, and when you have alternating current, basically you are combining two direct current at different frequencies, and it came out to what we see here as a sine wave. And again, in FD, there has been some studies showing efficacies. What about gastric paralysis? You have the enterotherapy that I mentioned early on using short pulses. You have the transcutaneous form of vagal nerve stimulation. You also have transelectrical acupuncture being useful in gastroparesis. So I'd like to conclude is that the pathophysiology for electrical neuromodulation is important in understanding the rationale for this therapy. Some of these terms, gate control, neuroplasticity, neurogenesis, are particularly important. So the method of electroceutical will include either direct through the nerve or serosa or indirect through the skin. And of course, all of these methods have their advantages and limitations. There are also studies showing efficacy of these electroceuticals in certain disorder of gut-brain disease, including fecal incontinence, functional dyspepsia, and gastroparesis. But we do need larger RCTs and understanding the mechanistics and development of better devices. With that, I thank you very much.
Please join us. Yeah. So I think now the house is open for questions, and because of the scarcity of time, we have been advised 3 questions. So, yes, please.
This is Dr. Salunke from Pune. This is for Dr. Kaul. Any talk about LPR? You need different probes. You need a probe which is having a sensor above the cricopharynx. So most of our probes are only detecting reflux below the crico. How do you confirm that? If you have references from ENT for LPR, how do you approach a case?
Sorry.
Laryngopharyngeal reflux.
So, can you hear me?
Yes.
So that's a whole other. Yes, you can have a pH probe in the proximal esophagus, not in the pharynx. There was a device that we had that was only putting it through the nose and the pharynx. It was not a whole pH probe, but that didn't work out. There was a lot of disconnect between the findings on that and the reflux that we measured. Because if you're going to have laryngopharyngeal reflux, you should have it here as well. So it wasn't picking up here, but it was picking up in the face. So that didn't pan out. So yes, you can have in your regular pH impedance probe, you can have a sensor up top. Yeah,
Okay, thank you.
and it's available actually. You can ask for those types of sensors. It can be customized.
Do you mean to say, do you attribute that reflux to aspiration pneumonias? Because most of the studies have no evidence which says GR causes that LPR and causing evidence. Please, that was a further continuation.
Yes. So thanks for bringing that up, Yogesh. There's controversial data on that. So some people, there are papers that actually have shown a positive association, and there have been papers that have not shown any association. So I think the jury is still out. It's not confirmatory just because you have 80% proximal episodes that for sure you're going to have laryngopharyngeal reflux. You have to look at other things as well, see what the laryngeal findings are on a laryngoscopy and go from there. Now, only laryngoscopic findings are also not confirmatory for laryngopharyngeal reflux. We've shown that as well, because they don't, just because you have inflammation of the arytenoids or the epiglottis doesn't necessarily mean it's from acid reflux.
Yeah. The second question is to the second speaker. What is your personal experience about temporary GES and permanent GES? Do you use it frequently, or you go ahead with the new device which you said, gamma core or transcutaneous stimulator? Are there any head-to-head trials, or do you go ahead first with transcutaneous stimulation for gastroparesis refractory and then go ahead with temporary GS followed by permanent GS? What is your say on that?
Personally, I don't have much experience with like the Entera or Gamma Core because these devices are, not really available in my part of the country. And for gastroparesis, we still, very much depends on the old method of either, of course, using the medication and also doing the old form of stimulation. So to be honest, I suppose we do. I don't think there is any like a direct trial comparing, different methods. Obviously, many of these newer methods are just probably early stage, and not all of them are actually approved for FDA in the treatment, right? Definitely, I do think that there is no direct trial comparing these various form of methods.
So if I may.
Yeah, of course.
So we do a lot of electromodulation therapy for functional GI disorder, which are now called disorders of gut-brain interaction, which is again going to be possibly changed to gut-brain microbial disorder or microbiota disorders. So anyway, it's still evolving, but we do IB stimulation, ear auricular nerve stimulation. It's a device that you place on the ear Monday through Friday. You take it off for 2 days. You do it for 4 weeks. And they've shown significance from our center. We are the largest center in US that has done that. And they've shown them some very good results with that. Then we've done gastric electrical stimulation, not the gamma core, but gastric electrical stimulation in patients with nausea and vomiting with or without gastroparesis. So you may have normal gastric emptying, but have normal significant nausea and vomiting, which is non-responsive to medication. We've done gastric electrical stimulation for them with pretty decent results, 60% improvement. We also do sacral nerve stimulation, which has been helpful in kids with idiopathic constipation that have fecal incontinence. It doesn't increase. We've shown that it doesn't increase the number of bowel movements, but it increases the frequency of, decreases the frequency of accidents or soiling.
Thank you. Thank you.
Yeah, last question, please.
So my question to Professor Kaul, almost similar to previous two questions. Like, sir, you have shown in your data there is a retrograde cricopharyngeal dysfunction. So there will be a tight upper esophageal sphincter in that. So it is a protective mechanism because we do see these in achalasia patients also, like tight upper esophageal sphincter. And what happens actually in the laryngopharyngeal reflux, like supraesophageal reflux disease, whether it is a laxity, matlab, over a period of time, this UES become lax to produce a pharyngeal reflux. Like, what's your experience, Sandeep?
So I don't think it's known or studied yet because retrograde cricopharyngeal dysfunction is a relatively new condition. It's just been described. We just described it in kids for the first time, and we described manometric findings as well as impedance studies, as I showed you. So we're still, and it's just a handful of patients. So we still need more numbers to get to understand exactly what's happening. I personally feel it's a functional disorder and probably be included in the next iteration of the Rome criteria, Rome 5, unless it's already completed. I guess Dr. Lee would know more about that.
Yeah.
Any questions from the chairpersons?
One question for Professor Kaul. We are differentiating between GRD and other disorders like functional, you said, hypersensitivity, and NERD. How there is difference in treatment between this NERD, hypersensitivity, and functional dysphagia?
So for functional heartburn, it's not related to reflux. That's completely not a GERD related. It's a phenotype, but that's being replaced. It's actually being removed from the phenotypes and being taken over by the Rome criteria, the functional GI disorder or the DGPI. So it's being moved out of that realm right now. So in the newer iterations of the classifications, you won't see that included. So that's a more of a psychiatric, psychological kind of thing, diagnosis, and you treat it accordingly. Reflux hypersensitivity, it could be related to not just acid reflux. So just doing treatment with acid reflux is not PPIs or is not going to really help because yes, it'll decrease your acid reflux events, but it'll just convert them into non-acid, and you still can have the symptoms. So PPI may not be helping the symptoms in reflux hypersensitivity. So sometimes in those patients, sometimes fundoplication could be helpful if the symptoms are debilitating and to the point where, so just to for the audience, the number of fundoplications that we are doing now in the United States has significantly because of a lot of medical legal cases that happened where GERD was misdiagnosed. I remember a case that I was personally involved with. There was a kid that came to us with actually had rumination syndrome, a 13-year-old girl, and had a fundoplication for rumination and just got much worse. And the patient sued the doctor, and the person didn't read the impedance well because the diagnosis was staring in the face. They just went by the software, and the software said, well, the patient has 200 episodes of reflux. Its acid reflux exposure time is elevated. It met all the criteria for reflux, so he diagnosed her reflux, not calling it rumination. And the patient went for surgery unnecessarily, and the symptoms got worse. So there have been a lot of cases. So the number of fundoplications has significantly reduced in U.S. They have to be very, very careful in the patients that you send for fundoplication. You as a gastroenterologist have to be completely 100% convinced that this is reflux. This is not a mimicker of gastroesophageal reflux, including EOE, because you can have a completely normal esophagus, appearing esophagus. If you don't take biopsies and the patient could still have EOE, then you're in deep trouble.
Okay, with this, I think we'll end this session. I would like to thank the speakers as well as the chairpersons. Thank you very much.
Thank you.
Thank you.